Hello everybody, welcome to my channel. This is a pathology video on gastrointestinal pathology. This is the third in the series of videos on inflammatory bowel disease. The topic is Crohn's disease and it's by Dr. C.S.B.R. Prasad, Professor of Pathology, Sri Devarajaras Medical College.
Coming to the second disease process, that is Crohn's disease. Crohn's disease is described by Bernard Crohn, and it can affect any portion of the intestine right from the oral cavity to the anus. And the most commonly it is the terminal ileum that is involved, and the important feature of this Crohn's disease is skip areas. That means there are involved areas of the segment. In between the involved area, the intestine may appear absolutely normal. Another important clinical finding in Crohn's disease is its association with fistulas and fissures. And again, any patient with recurrent attacks of fistulas and fissures, think of the possibility of Crohn's disease. And rarely, this inflammatory process may involve other organs like pancreas and liver. So, involved segment of the intestine will be thickened and rubbery in consistency, and they are with a narrowing of the lumen. This narrowing is due to inflammation, fibrosis, and hypertrophied muscular propria. And because of this narrowing of the lumen, it produces what is known as string sign appearance in the barium series in the X-rays. And there may be skip lesions morphologically, and intestinal mucosa appears cobblestone-like. So cobblestone-like, and this cobblestone-like appearance is due to the deep ulcers. Narrow, deep ulcers are the feature of Crohn's disease. If you recollect ulcerative colitis, they are wider and shallow ulcers, but in the case of Crohn's disease, ulcers are narrower and very deep. It can go through and through the intestinal wall, even extending into the perichoric fat and joining the adjacent organs. So in between these ulcers, mucosa protrudes in the form of polyps or knobs, which gives what is known as the appearance of a cobblestone. So hence the cobblestone appearance is typically used to describe the appearance of mucosa in Crohn's disease. In addition to that, because inflammation involves the entire thickness of the wall of the intestine, there may be reaction mainly in the form of creeping fat. Creeping fat, that means momentum or surrounding fat, encroaches onto the inflamed area, and this is a very typical sign of the Crohn's disease. And because of this fibrosis, thickening, and it results in what is known as stricture formation and narrowing of the intestinal passages made due to stricture. And this is the string sign. You see the arrow showing narrow, long segment of intestine characterized by radio-opaque material, which is something like a fiber that is present and joining the two ends of the dilated segment of the intestine. And this is diagrammatic representation of the terminal portions of the ileum joining the cecum and showing the thickening of the wall of the intestine, and there are deep ulcers which are going through and through and joining the exterior producing fistulas and joining the internal organs like surrounding large intestine producing enterocolic fistulas. And here the clinical images on the right hand side showing the pelvic fistulas, on the left hand side perianal fistulas, which is very common in the case of Crohn's disease. And this barium series showing a communication between the small and large intestine, which we will call as enterocolic fistula. So morphology, microscopically, you will see neutrophils in isolated crypts, that is cryptitis, and architectural distortion, that means villus blunting, atrophy, and there may be metaplasia. So what is important and specific for Crohn's disease is transmural inflammation. That means every layer of the intestine is involved in this inflammatory process, and it produces granulomatous reaction. And these granulomas are non-caseating. So just recollect the tuberculosis granulomas are associated with caseous necrosis, whereas in Crohn's disease there is no caseous necrosis. And in addition to that, the patient may have strictures and strictures due to thickening of the muscular intestinal wall. So transmural inflammation, ulceration, transmural inflammation can be appreciated very well here, and granulomas can be seen in that pale areas near the serosa or granulomatous inflammation. Look at this ulcer, which is going through and through the wall of the intestine. So this is deep penetrating ulcers which may produce what is known as fissuring. And this is the typical appearance of non-caseating granulomas in Crohn's disease. So clinical manifestations depends upon the site of the disease and patterns of affection. Say for example, if the fibrostenotic obstruction, then probably the patient will come to you with intestinal obstruction. If it is penetrating and communicative type, the patient may come to you with fissures and fistulas. And depending upon the site, we classify them ileojejunal, ileocolic, and colonic, exclusively colonic. So in the case of ileojejunal, small intestine, entire small intestine may be involved, and because of this, patient will have malabsorption to vitamins, malabsorption to fat, and probably these patients may have either what do you call that, megaloblastic anemia. In addition to malabsorption, weight loss is very common in these persons. If you look at the middle one, that is ileocolic variety, and because of the terminal portions of the ileum is involved, the patient may be suffering from megaloblastic anemia, and the large intestinal involvement brings the patient with dysentery type of manifestations. And if it is exclusively colonic involvement, the patient may have dysentery type of manifestations. So Crohn's disease, clinical features depending upon the region that is involved. They may suffer from malabsorption, nutritional deficiency, and pain, weight loss, and also strictures and fistulas. So fistulas produce a typical clinical presentation. Say for example, a patient who develops duodenocolic fistulas may come with fecal vomitus, or the person who develops rectovaginal fistulas may have feculent vaginal discharge. Intravesical fistulas, probably the patient complains of pneumaturia, that is passage of gas during micturition, and the fecaluria is another typical finding in these persons, which may be important in clinching the diagnosis of complications of Crohn's disease. And other complications: serosal adhesions, perforations, peritonitis, intra-abdominal pelvic abscess, perianal abscess, and obstructions, which we dealt with in the previous slides.
Thanks for watching. Please subscribe by clicking the button subscribe.